Thank you, Peter, for the introduction, and thank you to the organizers for the opportunity to speak here about biomarker research in upper airway disease. So very quickly, the roadmap of my presentation, I will talk about ideal biomarkers, why we need biomarkers, where to position different type of biomarkers for type 2 and non-type 2 endotype, and the implementation in daily practice. So a lot of research nowadays is focusing on markers of biological activity. So it's showing a difference between a diseased compared to a healthy situation. It's showing an association between a certain marker and a disease. But in order to move towards clinical practice, we need biomarkers that also are validated for use into clinical practice, and this is what I will show in the next couple of slides. And in this way, we will be able to use these biomarkers to evaluate treatment response and monitor disease progression. So this table is nicely listing the ideal or the key characteristics of an ideal biomarker. The first item I already covered. You want it to be stable in normal individuals and to be different in disease patients, which is the most easy one. Then we want that they reflect changes in the levels of the underlying pathophysiology or changes according to the treatment. We want biomarkers to be measured in a quick way and by simple methods. This is easy, but in practice, you need to take a lot of steps to achieve that. Then we have high sensitivity, high specificity, high positive and negative predictive value, repeatability, so validation in independent cohorts is an important aspect, and preferably it's inexpensive to measure. So these are the first two steps into the development of biomarkers. We have a pre-discovery phase and a discovery phase. Discovery phase where we need to define also the biological sample. Do we want to have a biomarker in serum, in nasal secretions, in the tissue? This is something that needs to be considered. And also replication in independent cohorts. And then afterwards we can talk about analytical validation or validation for use into clinical practice. And this is what is proposed here by this SAFED approach. It's 5 different items which are a biomarker that is superior, actionable, valuable, economical, and clinically deployable. And all these steps are needed to enable that biomarkers can enter daily practice. So why do we need biomarkers? This is the mainstay of treatment in CRS. We have steroids, surgery, and also some evidence from phase 2 studies that biologicals might be beneficial in chronic rhinosinusitis. But we see that the response to treatment is variable for all of these. So therefore, I think there is a need for new biomarkers. So we see here that overall, if we look to the group of patients treated with steroids, we see a beneficial effect both in CRS without and with nasal polyps. But if we then look to the different studies listed here and here, we see that there is quite a variance in the degree of response. And also in single studies, a patient can be here or a patient can be here. So here is a need to identify responders. When we look at response after surgery, this is a study that we did, a 3 to 5 year follow-up study after bilateral FIS. And we looked to the disease control at that time, and we see that over 40% of patients are uncontrolled. So also here, there is a need to identify responders to surgery. And lastly, also the biological treatment. We saw in these phase 2 studies that there is a nice effect both for the omalizumab and the dupilumab, but still there is a spread in the response and the need to know and identify why certain people are responding to these treatments and why others not. Next reason why we need biomarkers is because we will have different biological therapies available. We saw already that we have omalizumab or anti-IL-5 or anti-IL-4 treatments, but all are actually looking at the type 2 endotype. So now we need to know which biological treatment to give at which patient. So for that we need to identify which pathway is activated in these patients with type 2 disease. We need to go into more detail, and we need biomarkers of each of these pathways, the IgE, the IL-5, and the IL-4, IL-13 pathway. So this summarizes that there is the need for biomarkers because of the variable degree of response. There is a need for identification of the biological treatment, also the response, and especially because there is a quite high cost associated with this biological treatment. So a trial and error approach here is not really ideal. It's not that. So where to position biomarkers? This is the endotype-driven treatment approach that was proposed by a collaboration between the European and the American Academy for Allergy and Clinical Immunology, in which you see that first we need to make a proper diagnosis. This is a really important aspect because a lot of the burden or some part of the burden of uncontrolled disease is also because of misdiagnosis. In the next step you can characterize the phenotype. So we look at the clinical characteristics of the patients, demographic characteristics which are listed here. And then in the next phase we can move to these endotypes and go into biomarker research to identify whether a patient is type 2 or non-type 2 and go more detailed in order to go to tailored therapies. So what do we know about phenotypes in ERS? We know that we have polyps and non-polyps. We know that we have a different degree of severity, recurrence of polyps. We have some other phenotypes like the aspirin-induced, the fungal sensitization, infectious CRS, CRS which is associated with CF. But we need to go one step further. This is based on expert-based opinion, but if we look at this study in which clinical outcomes are put into a mathematical model, and then we try to cluster patients based on these clinical outcomes, here you see that 5 clusters were identified, and we can group these patients based on only 3 clinical characteristics. One is productivity loss, one is the age, and one is the SNOT score. And now we need to know in the next phase how this relates to the endotype and the pathophysiological mechanisms of these patients. So in the next phase, we go to the endotype, so really looking at the pathophysiological mechanism underlying the disease. And whether we look at rhinitis or chronic rhinosinusitis, or whether we look at asthma, a lot of these pathophysiological mechanisms are shared. And this is visualized here. We have the 4 endotypes listed: barrier dysfunction, neurogenic pathway, type 2 pathway, and the non-type 2 pathway, which are linked to one or more of the phenotypes and the symptoms identified here. This slide we saw also presented by Klaus Bachert. I just want to show here that it is not black and white. It's not really type 2 and non-type 2. We can have patients with non-type 2 disease, with intermediate type 2 disease or high type 2 disease, but you also see that these highly type 2 patients have increases in IL-17 or in IL-8, and we need to better understand what happens there. I think these are really the very severe patients in which a lot of different pathophysiological mechanisms might be activated. And this is also what we found in our asthma cohort of 205 patients, in which we looked at the cytokine expression levels in the induced sputum. And we see that there is a cluster of patients, the first one, in which IL-5 is increased, but also IL-17 and IL-25, which was not expected on beforehand. But these were really the ones with the worst lung function. Another cohort in China, also cluster analysis, but not now only on the biological parameters. Also here the clinical characteristics were taken into account in this cluster analysis. And in this way you see here that we have type 2 endotype, we have non-type 2 endotype, but we also have a group of patients which have very severe disease, so high nasal polyp scores, but in which this type 2 or non-type 2 disease is absent. So we still need to further, or try to further understand what is happening in these very severe patients. So most of these cohort studies and these cluster analysis were on tissue collected during surgery. So these require quite invasive techniques. And now I think we need to go to a next phase in which we can identify new biomarkers which associate with the findings that we have here, but which can be easily implemented into daily practice. And then we think about peripheral blood, nasal secretions, or nasal lavage. So very quickly here, we have this type 2 immune response, so many possibilities, many biomarkers that can be identified. But again here, we need to validate the findings that we have. We have IgE, eosinophils, nasal NO, and some immune mediators, for which we have already some preliminary proof that these could be potential biomarkers that are easy to detect. So this is a very recent study. So from this cluster analysis, it was clear that you have patients with high IL-5 in the tissue and low IL-5 in the tissue. In this study, they tried to look at serum markers, so periostin, IgE, and Staphylococcus enterotoxin, IgE, as biomarkers to predict whether or not tissue IL-5 is present. And they could identify that the serum periostin was the best candidate to predict with a quite high sensitivity the presence of this tissue IL-5. Another study from a Belgian colleague in which they looked into nasal secretions, to the eosinophils, eosinophilic mucin, and fungal hyphae, in which they could show that if you have all of these, that the likelihood of recurrence of disease in nasal polyp patients is higher compared to the others. So I will go quickly over these. Also, some studies have been done with nasal NO. We would have expected that the nasal NO would be increased because NO is a gas which is induced by the IL-13, which is a type 2 cytokine. We would think that we would see increases, but what we see here is that patients with nasal polyp disease have decreased levels of nasal NO. And I think this next slide explains this finding, because if we look at baseline or post-surgery, we see that the nasal NO increases. So this NO is produced in the sinuses. You clear the obstruction, and then the NO more easily can be measured. So then I will move to my last slides. where I think this is a nice summary of a combination of the different endotypes, combining it with potentially easy to measure or easy to detect biomarkers, the blood eosinophils, the serum IgE, and tissue eosinophils, in order to identify whether or not a patient is non-atopic, atopic with eosinophils, or atopic or Th2 low. And lastly, I want to show this slide, which was recently published in the new journal Rhinology Online, which was the result of a brainstorming discussion we had last November on obstacles for endotype-driven treatment, in which we identified that it's important to know who, where, and when to do endotype-driven treatment. Thank you.